This is Ezekiel Emanuel from the University of Pennsylvania in Philadelphia in the United States. I'm talking about the future of healthcare reform, lessons learned from the United States, and their applicability to China. Let me remind you that in my second slide, that in March 2010, the United States passed the Affordable Care Act, which was landmark legislation reforming the United States' healthcare system. Now, how can we ensure in modern countries that every citizen gets health insurance? There are fundamentally three ways. First, states can provide all healthcare services to their population. That's kind of old-style Canada, where the states really give every service. Second possibility is states can provide a sort of minimum with providing opportunities for people to buy additional insurance or buy up or get insurance that takes over some of the services which are limited in the state. That's Britain today, that has the National Health Service but has some private insurance. The Netherlands, which provides basic insurance but allows people to buy up. Israel has a similar system where people get to choose from one of 4 managed care companies and their supplemental insurance to cover additional services. The third option is that a country provides mandate for people to buy insurance, and then because health insurance is very expensive, the government provides people subsidies to buy insurance. The third is the model that the United States has adopted for its healthcare reform through the Affordable Care Act. Now, there are multiple elements of insurance reform in the Affordable Care Act. On slide 4, which says the ACA key insurance elements, it provides for universal coverage, mandating that individuals buy insurance. For low-income individuals, there's a government program. For individuals with slightly higher income, there are these marketplaces or insurance exchanges where individuals can purchase insurance, again, with government subsidies. There are reforms to the marketplace so that insurance companies have to compete equally. They all have to provide insurance and renew it to individuals. They can vary the price of insurance based on only 3 factors: geography, what state they sell the insurance in, the age of the individual, because we know older individuals in general are more expensive, and whether the individual smokes. They cannot change how much they charge in a premium based upon sex or pre-existing condition or income or any other factor. In addition, there is a requirement that the insurance provide a minimum. In the United States, we call this the 10 essential healthcare benefits. These benefits are part of not just the exchanges, but all insurance, whether provided through the employer or these exchanges, must provide those same benefits. I'm now on slide 5, talking about the ACA health insurance exchanges. Now, these insurance exchanges are government or not-for-profit entities. They solicit insurance bids. They organize the insurance into tiers in the United States. And then they market them to make sure that the insurance fits the requirements and allows individuals to buy those insurance. Basically, the exchange is a portal, an e-commerce portal that allows qualified individuals and small businesses to purchase health insurance. In the United States, the health insurance occurs in 4 tiers, and people can choose different tiers. People are subsidized to the second lowest silver plan. Subsidies are available for some members of the population, roughly families up to $100,000 in income per year. Now, many of you have probably been taught what is known as the iron triangle of healthcare. You can have high quality, low cost, and high access. And it was often said, certainly when I was becoming a doctor, you can have only two of the three. You can have high quality, widespread access, but then you're going to have high cost. You can't have low cost. Or you can have high quality and low cost, but not everyone can get health insurance. Well, I'm here to tell you that this iron triangle is not true. You can have high quality, low cost, and universal access in your healthcare system. And the reason in the United States that we can have this change is that the cost-quality trade-off that people often say, high quality requires high cost, is false if you're not out at the frontier for performing efficiently. If there are inefficiencies in the healthcare system, you can improve your quality and actually lower your cost. And that would be going up from that dot towards the frontier. But the important point is that neither in the United States, nor in China, nor I might say anywhere in the world, are we actually operating at the frontier where we are maximum cost and quality, and to improve quality, you would have to increase costs. That I do not think is where we're at today. I'm on the slide that said, what is the applicability of the U.S. healthcare reform for China? What are the lessons that you in China can learn from the American healthcare reform, the Affordable Care Act? Well, I think there are three inevitable worldwide trends called megatrends that are going to happen to every large developed country. Not going to happen in Africa, but they're happening largely in our country. One is the dominance of chronic conditions. Another is the movement of care out of hospitals. And the third is a standardization of care and enhanced performance measurement of doctors, seeing that they're actually doing a good, top quality job and not wasting resources. So let's talk about each of these megatrends. First, the prevalence of chronic conditions. In the United States, 36% of all Americans have one or more chronic condition. 86% of all healthcare spending goes for people with chronic conditions. And we know that the 10% of Americans who use 2/3 of the healthcare budget, those are largely people with chronic conditions. So we have a lot of chronic conditions, and they're only going to grow as the population ages. So the focus on on healthcare has to be handling these chronic conditions. It's not about acute problems, car accidents, or industrial accidents. It's about chronic conditions: diabetes, high blood pressure, congestive heart failure, coronary artery disease, cancer, asthma. That's where the money is going. And any modern healthcare system is going to have to focus in on people with chronic conditions. Because they're chronic, because people live with them, the best interventions are not going to happen in the hospital. They're going to happen as people live in everyday lives. Second megatrend is moving care out of the hospital. Now, these are data from the United States. And what you can see here, this is hospital admissions per 1,000 people, is that we have actually had a substantial decline in the number of people hospitalized in the United States. It peaked in 1981 at 171 out of every 1,000 population being admitted to the hospital, down to 109 a few years ago. What that tells you is that more and more care is going out of the hospital. Well, I'm a cancer doctor, an oncologist working on breast cancer. And when I trained many years ago, we often used to admit people overnight for chemotherapy. That doesn't happen anymore in the United States. We also used to admit patients overnight or for several days to replace their hip, for a hip replacement. We can do that with 24-hour admission and provide better quality care. So we've had a lot of movement of care out of the hospital. This is reflected not just in the decline in hospital admissions, but also in the decline in hospital beds. You can see that there's been, between 1975 and today, there's been a substantial decline in hospital beds, going from 1.33 million to 868,000 hospital beds in the United States, all the while as the population has been growing. So again, a drop in hospital admissions, a drop in the number of hospital beds, And the concomitant result is a dramatic increase in the number of patients getting outpatient visits. So we've now had 1 billion outpatient visits for the United States population of roughly 320 million people. So a shift of care away from the hospital and towards offices and outpatient facilities. So we've had more chronic conditions with a focus of the healthcare system trying to take care of these chronic conditions. We've had a shift of care out of the hospital to what we call the outpatient setting, physician offices and other clinics. And the third big check is we're changing, so we have more standardization of care and more performance assessment of doctors, creating a positive feedback. So this is a graph. I'm now on standardization and performance measurement. This is a graph of the doctors prescribing generic medications in a hospital in the United States, actually at my hospital, the University of Pennsylvania's hospital. I'm now on the slide that says current challenges in China. Well, how does this megatrends affect China, and what ought China to do? So there's clearly prevalence of chronic conditions in China. There's an unequal distribution of healthcare resources in China, and there's excessive reliance on hospital care. 140 million Chinese people are now over 65 years of age. That will increase to 230 million by 2030. And we know that old people have a lot more chronic conditions, so you're going to have an expansion in chronic conditions. You also have limited caregivers for adults because of the one-child policy, which is going to strain how people can actually care for their elderly relatives. Chronic conditions now account for over 80% of the deaths in China each year, and 10% of all Chinese adults. Over 110 million people already have diabetes. And again, as the population ages, as sedentary lifestyles become more common, as junk food becomes more common, diabetes is going to be a major problem for China. So China, like the United States, the focus has to be on chronic conditions. What can we learn from the United States? Well, places that will succeed with chronic conditions actually focus a lot of attention on people who have chronic conditions. They actually work with them. One group in the United States at CareMore, which is in Los Angeles, has a new group of doctors they call extensivists, and they focus on high-risk, chronically ill patients. These are physicians who oversee patients' care before, during, and after a hospital care. They develop relationships with the patients, and they encourage making decisions with the patients. Often the extensivists actually go to patients' houses to make sure everything is going well. How does CareMore succeed? Well, actually, they do very, very well with this sick elderly population. They have 20% fewer hospital admissions because they care for patients at home. They have 23% fewer bed days. That's the sum total of the number of days patients are in the hospital. Again, because they're able to care for patients at home much cheaper. And their length of stay is 4% less. So by creating a new specialty of extensivists, focusing on chronically ill patients, I'm now on unequal distribution of resources in China. You know that hospital beds per 1,000 population are heavily skewed towards large urban areas, and the population doesn't ideally match the population, especially in rural parts of China. What do we know? Well, if you want to have a more even distribution and have money follow people, subsidies to buy insurance or to get health care must be based upon income, not geographic location. If you base it upon geographic location, you will have an unequal distribution, and it will be hard to provide high-quality care to large portions of the Chinese population. The government should consider using special purpose grants or incentives in economically underdeveloped regions to get people insurance, to get people healthcare services. The most important thing, I think, though, for China is this focus on hospital care. In 2016, China had 29,000 hospitals. In 2015, there were 2,000 new private hospitals introduced in China. The Chinese healthcare system is excessively focused on care in hospitals. The big goal of the Chinese reforms are to move patients from one-tier hospitals down to lesser-tier hospitals. But that is still focusing care on patients getting hospital care. That's a mistake. You have to focus care on moving out of the hospital. Every country in the world is following the United States' example of moving care out of the hospital. China has to also. China has nearly 65% of all its health expenditures for hospital services. Germany spends 29% on hospital services, and the United States spends just 32% on hospital services. Half of what China is spending on hospital services. One of the problems for China is that physicians are licensed to hospitals. That has to change. Physicians have to be able to open up their own offices or clinics and care for patients away from the hospital. Similarly, let me just suggest, patients are kept too long in the hospital in China, maybe because you haven't developed good outpatient facilities and good home care. So the average length of stay of a patient in a Chinese hospital is 12.1 days. By comparison, in the OECD, it's only 6.5 days. In the United States, it's even shorter because staying in a hospital is so expensive. So China has to do something to move care of patients out of the hospital and to get hospital stays shorter. There is no way China is going to be able to build enough high-quality hospitals to meet demand for health care with more chronic illnesses. Furthermore, it's not ideal to treat chronic illnesses in a hospital. These are chronic conditions that patients live with every day of their life. It turns out this is consistent with the business literature, where people who study the change of organizations or the transformation of organizations say it takes 4 years to put in these changes. So if China puts in big changes, it really has to follow it for 4 years and not expect change overnight. But we are going to see, we're seeing transformation in the United States, we're going to see transformation in China. Lazard, the big investment banking firm looking at the American healthcare system, concluded, "We found surprisingly strong sentiment that the industry will be transformed over the next 5 years to 10 years by the development of new pricing models broadly known in the United States as value-based care. The response indicates that value-based care may have even more of an impact on changing healthcare than scientific breakthroughs leading to new drugs and new devices." So here you have a big investment bank making big bets in the American healthcare marketplace, saying 5 to 10 years, the biggest changes from changing payment, not new drugs, new devices. China has to commit itself to making changes both in its insurance market so everyone can get insurance and it can be efficient. You're not selling individual by individual. The ACA is a good model for that. Or by changing how you deliver care to move it out of the hospital, to get physicians to work in offices. Now, my last slide is a plug for a book I wrote on how the American healthcare system is changing and how it can be helpful. And then at www.improvehealthcare.net, a series of online courses on how you might change healthcare to ensure higher quality, lower costs, especially for people with chronic illness. Thank you. I hope this discussion of insurance reforms in the United States and the Affordable Care Act, as well as challenges that face China and how they can be addressed, is very helpful. Sorry I couldn't be there with you in person. I hope this video is a useful education for you. Thank you very much.